This podcast is Module 3, the concept of comfort. We're going to be looking at just the general overview of what comfort is, and then also discussing pain, acute and chronic pain, and sleep and rest disorders. Here are your learning outcomes, and here is a definition of comfort that your book uses. So just a brief physiology review. Maslow's hierarchy of needs is where we need to start with somebody to ensure that they are comfortable. Because if the physical needs are not met, we can't look at the sociocultural, the psychospiritual needs. So always start with Maslow and those physical needs. When we're collecting subjective data, we have to understand what is normal for that client, and often clients may have difficulty articulating what is not comfortable. It may not necessarily be pain, but they may have a difficulty explaining to you why they feel that they're uncomfortable. Objective data, sympathetic nervous system responses is what we're going to be looking at. The presence or absence of pain, the degree of sleep and rest, balance of nutrition and fluids. So lifespan considerations, we want to look at infants. May be challenging to discern the cause of their discomfort. They're either wet, hungry, or they have pain. So that sometimes is difficult to assess. Older adults may have higher pain threshold but lower tolerance. There may be some cognitive impairment. They may suffer from sleep disorders. And ethnicity, be culturally competent. We're going to talk about ethnicity and certain cultures and how they express pain. Genetic considerations and non-modifiable risk factors. There may be some diseases that are associated with discomfort, such as rheumatoid arthritis, Parkinson's, things like that. Some genetic disorders directly affect the individual's ability to perceive pain. Genetic mutations are associated with some sleep disorders. Many psychiatric disorders have a genetic component also. So we're going to talk about acute and chronic pain. And there are your outcomes. So what is pain? It's unpleasant, highly personal, could be physical, emotional. Others may not realize that somebody's in pain. It can consume all parts of a person's life. You can have a sensory and an emotional experience. The most important thing is pain is whatever the client says it is and exists whenever the client says it does. So it's not something that we can determine with any objective data other than we may see changes in their vital signs. They're going to give us a pain scale, but yet it is what the client says it is. Typically, pain is described in terms of the location, the intensity, the quality, the duration. Can be medically described based on the etiology, what's causing it. So, location. Typically, it may be used to give a primary indication of the underlying cause, such as back pain. You can also have radiation, and that is pain that spreads or extends to other areas. Say, for instance, the low back may have radiating pain down the legs. Referred pain is pain that appears to arise in a different area of the body, such as if somebody is having a heart attack, they have cardiac, the problem originates in the heart, but yet the pain is felt in the jaw, so referred pain. Intensity, mild, moderate, severe. The standard scale for pain is typically 0 to 10. Be careful that you know what scale your facility is using, because some places do use a scale of 0 to 5. So a pain of 5 out of 5 is very different than pain that is 5 out of 10. So just make sure that you know what scale your facility is using. Visual scale, you're going to be looking at faces. If somebody, especially children or somebody who doesn't speak English, we may need to use the faces scale. And again, they are divided into faces that show mild, moderate, or severe pain. So the quality of the pain. These are words that your patient is going to use to describe their pain: stabbing, burning, itching. You can read over that whole list. Try not to put words in their mouth. Ask them if they can describe their pain. And if they're having a difficult time, you can suggest a couple words such as burning or itching or, is it just tender? But they may just agree with whatever you're telling them. So yes, it's an aching pain, when really it's more of a stabbing pain. If we can understand and get them to describe the quality of their pain, sometimes we can determine whether it is tissue damage, nerve pain, muscle pain, or visceral pain. So two types of pain: acute pain and chronic pain. You have acute pain, which has a very sudden onset. Identifiable tissue injury could be a surgical incision or a broken bone. Typical autonomic responses. Duration is typically less than 6 months. So until the injury or the incision heals, there is a known end time that pain should cease. So the three categories of acute pain are: you're going to have somatic, which is the skin and the muscles. You're going to have visceral pain from the body organs, and then referred pain, sensed in a site other than the origin. So in other words, you have your cardiac pain, but you have your cardiac cause, but then you have pain in the jaw or shoulder. Chronic pain is prolonged pain more than 6 months. It's not always a known cause. Physiological adaptation of autonomic responses, whereas with acute pain you have typical autonomic responses, and with chronic pain the body has adapted to that chronic pain, so you may not see changes in their vital signs with the autonomic responses. Three categories of chronic pain. There's recurrent, where the patient may have periods of having no pain. Chronic, intractable, benign means that there's always pain there, but the intensity varies, and that's typical with back pain. And then you have chronic progressive. This is pain that just gets worse over time, and cancer pain is one example. You also have breakthrough pain, and this is when transient exacerbation of pain that occurs spontaneously or in relation to a specific predictable or unpredictable trigger. So examples are: you may have an incident, short-term, predictable, such as somebody who has pain when they cough, or they know that there's going to be pain when the dressing to their wound is changed. You can also have idiopathic, no known cause. It tends to last longer than incident pain, and it's harder to treat because of not knowing the cause. End of dose medication failure. Background pain is usually not controlled, and this is when somebody has pain before their next pain medication is due. Central pain is caused by damage to the nerves in the CNS due to either stroke, MS, Parkinson's, or a trauma. May occur immediately or may be delayed. Constant pain along with pain paroxysms or sudden spasms. Evoked pain, which is the potential to have pain. and allodynia, which is the perception of a painless stimulus as painful. Described, often it's described as pins and needles, burning, aching, lacerating, shooting pain. Maybe less able to feel normal touch. This is very similar to the sensation that you get when your hand falls asleep or your foot falls asleep. Phantom pain is pain felt in an amputated limb or body part. It's usually reoccurring rather than being constant. It's usually described as shooting, stabbing, squeezing, throbbing, or burning, and it's associated with a neurologic activity in portions of the brain that once connected to the amputated body part. So it is real. It is what the patient says it is, and it does exist when the patient says it does. Psychogenic pain is pain that is associated with psychological factors. This pain is real. Treatment should include interventions for pain and emotional distress. So for each client, there's a unique set of factors that influence how they perceive pain. You can have a physiological factors. How do they express their pain? Physiological changes, you have pulse increases, respiration increases, but you need to remember that in children, they normally have a higher pulse and respiration, so we can't always, across the lifespan go by just the physiological changes. Developmental stage, obviously children and babies can't verbalize their pain, so that they do a lot of crying, whining. Ethnic and cultural values. There are cultures that don't express pain. They're very stoic. And there are other cultures that are very verbal about their pain. So page 159 in your book has a good list of some myths that we run into with pain. The environment. Remember that the hospital is an unfamiliar environment to most patients. Support does make a difference. It is generally found that if somebody has support of their family, friends, that they do better, that their pain perception is usually better. Past experiences. They may have experienced pain with a treatment before. They may have witnessed somebody who was not given adequate pain control. And also the meaning of the pain. Is it temporary? What happens with the pain? Developmental stage, again, we want to know the developmental stage of the child, the patient. How do they express their pain, and how do they respond to pain? Those things are going to depend on the developmental stage. So I'm going to stop here and begin with comfort part 2.